for actually filling the defect afterwards with a product called Vitos. Okay, and this is just more footage of the bilateral approach to the back that I was talking about before. So I'm going to be just kind of closing it up, but just to demonstrate that the work that's being done with the MIS and the percutaneous approach to the spine, the collection of the data is something that I've been doing for the last 5 to 6 years, and I just wanted to demonstrate some of the results that I've had. So I've gone through this. This is the rationale for the percutaneous approach. It's less muscle destruction, less blood loss, low incidence infection, and lower pain medication requirements. And one of the devices that I've used is this OptiMesh device, which is this collapsible Dacron mesh cage, and it's inserted through an 8mm portal, and once in place is expanded through the packing of allograft and autograft bone. And the principle underlying the effectiveness of this device is something known as granular mechanics. And the device goes into place, the bone is packed into place, and it's through the sharing of these forces that a significant load can be borne by the device. So with the technique that I've been using, I use a combination of allograft bone, 8 to 10 cc's, consists of 80% corticocancellous, so 20% demineralized bone matrix. We use some autograft bone, about 4 to 6 cc's, which comes from the iliac crest in a minimally invasive manner, and we use some bone marrow aspirate. And the combination of these allows for a significantly improved fusion rate. So the biomechanical, one of the issues, again, with the percutaneous and the MIS approach was, are we able to achieve fusion to the supposed rates that an open case does, and can we restore the spine biomechanically? And I don't know if you can quite see it, but this slide shows a significantly collapsed disc space here on the right. And the space has collapsed so much so that we could only just about insert this 18 gauge needle. Once the needle is in place, it's over that needle and stylet and guide wire that we use the dilators to allow us to insert this load-bearing device and restore the intervertebral height and indirectly decompress the neuroforamen. And the indirect decompression is advantageous because there's no need for us to go down and resect any of the bone because the nerve is released just through the insertion of this device. And this demonstrates the biportal approach I was talking about before. And this slide again shows the relatively small number of instruments, but the key instruments that we have, that we use for this approach. And this is the sheath, this is the shaper in its collapsed format and in the expanded format. And this is one of the rongeurs that we use. So in the patients that I included in the study that I did, my inclusion criteria were patients who had recurrent disc herniations after failed surgery, patients with symptomatic foraminal stenosis with loss of intervertebral height, patients who had symptomatic degenerative spondylolisthesis but not greater than grade 2, and failure of conservative treatment greater than 6 months, and low back pain with a greater than 4 on the VAS. Exclusion criteria was an infectious spondylodiscitis. So the study and the model study was a 2-center retrospective study. Included in the study were patients with 1 and 2 level disc degeneration from L3 down to S1. All patients received pedicle screw fixation. The outcome measures which were taken preoperatively, 6 months, 12 months, 18 months, and 24 months with the VAS, the Oswestry, X-ray assessment of fusion, AP and lateral, and the incidence of complications. So I'm going to go back to a video file again to demonstrate the technique here. So this is just a video clip of the technique associated with the case, and again you can see I'm coming in from the posterolateral aspect of the disc space. Go down with some dilators and some sheaths. And this was a video clip actually of one of the earlier cases where we were using a uniportal approach, and that was subsequently modified to a biportal approach. But again, fluoroscopic guidance in both the AP and lateral views allows us to access the disc safely. And then we use, this is the shaper that I'm inserting through the sheath. And rotating that frees up the degenerated material in the disc space. And we use pituitaries to go in and evacuate the material, take it out. And we'll take the decompression through to the anterior aspect of the disc space. This is a frame that we attach to the railings on the bed. The frame is then attached to the sheath to stabilize it, and we've positioned the tip of the sheath at the posterolateral margin of the disc space. So this is the interbody device was inserted, and I'm going to start packing bone into place now. And we have these. We put the bone into the cylinders. The cylinders go down the tube into the mesh cage, and you can see the space is starting to fill up over here. So the interbody device has been inserted, the bone graft has been placed into the mesh cage, and then before I withdraw the sheath, I'll put an endoscope down just to make sure that there's no free fragments floating around or no fragments moving into the neuroforaminal space. Okay, and then this section of the clip shows the insertion of the screws into the pedicles. So we put this is the guide wire here, and then the screws are cannulated the pedicle, so we're moving the screw through. Put screws in at 3 or 4 or 5 in this case. And you can see it's the extent of the incision. It's a minimal incision. And this is we're able to insert the rod down into the screw heads here. Again, fluoroscopic guidance is key to this.
How long does surgery take?
An hour and a half, 2 hours. And then that's the final view. So the AP view with the screws either side and the interbody device in place. And so this patient was in recovery for about an hour and a half. She was discharged home, and she did very well. So again, this is just some X-rays. These are just some slides from some of the patients who were in the retrospective study, and this was a 2-level case that I did, where this was an immediate post-op view with placement of the screws and the interbody devices, and the utilization of fluoroscopy and now computer navigation allows a much more accurate placement of the screws than with a freehand open technique. It's just another slide demonstrating the use of a retractor sheath for a direct posterior decompression. And the reason I put this slide in here is that with the